Thank you for joining us and welcome to MLI's Community Collective, Harnessing the Power of Community to Battle Obesity. This is the first of a three-part series talking about the importance of starting a conversation with your patient about an obesity diagnosis that MLI is honored to bring to you in partnership with the Colorado Obesity Society. Part two will be another virtual activity using the same link you used tonight next week, Wednesday, November 6th at 6:30 p.m. Mountain. That will look at some of the new and emerging data on anti-obesity medicines. In the third week, we will all meet together for a live in-person event at the Welton Room in Denver on Tuesday, November 12th at 6 p.m. Our hope is that after participating in both virtual sessions, you'll join us live with any remaining questions or challenging cases. This exclusive event is for you to network with your colleagues so that you feel comfortable making a difference in the lives of your patients who face the challenges and comorbidities that come with overweight obesity. It's not too late to register if you have colleagues who weren't able to join us tonight. As long as they register, we'll be sure to put the link in the chat. This session will be available to them on demand at their convenience through the Zoom events portal. So tell your friends and make it a date. Now, before we get started, let's warm up with a couple polling and pre-test questions. Please answer on the pop-ups. Which of the following best represents your profession? Okay, next poll. What is your specialty? Primary care, obesity specialist, endocrinology, bariatric specialist, or other? Okay, thank you. And now for a couple pre-test questions. Among the following comorbidities, which has the greatest rate of co-occurrence with obesity? Next question. Your 44-year-old patient with a BMI of 36 kilograms per meter squared presents to the clinic for an annual visit. She has a history of dyslipidemia and hypertension. What % weight loss is needed to see a therapeutic benefit in her hypertension? And last question. Which of the following are true regarding semaglutide and tirzepatide? Thank you. We will be monitoring the chat this evening, so please feel free to ask your questions there, or even better, feel free to turn on your cameras or come off mute and ask your questions directly. And thank you so much for being here tonight, including those of you joining us via YouTube. With all that said, it's my great pleasure to introduce you to one of the leading experts in the field of obesity medicine, Dr. Jacinda Nicholas, who's an associate professor at the University of Colorado School of Medicine. She received her MD from Harvard Medical School and completed her residency in internal medicine and primary care, Brigham and Women's Hospital in Boston. She received her master's in public health from the Harvard Public School of Health and completed her clinical research fellowship in integrative medicine and general medicine at Harvard Medical School. Dr. Nicholas completed the NIH-funded Building Interdisciplinary Research Careers in Women's Health Scholarship and K23 Career Development Award testing on evidence-based mHealth intervention program delivered by mobile application called Bit After Baby. Her current research focuses on using technological approaches to promote adherence to lifestyle changes with the objective of preventing postpartum weight retention among women at elevated risk for cardiovascular disease and diabetes, as well as lifestyle interventions to reverse the metabolic syndrome and prevent cardiovascular disease. She practices both primary care and obesity medicine. She specializes in weight control throughout the reproductive cycle, including preconception, during pregnancy, postpartum, and through menopause. Dr. Nicholas, thank you for joining us, and I'd like to turn this activity over to you. You are on mute.
There we go. Thank you so much. Thank you for the kind introduction. And hi, everyone. Thanks for joining, even over the dinner hour. Feel free to eat while you're listening. So I'm going to do the first half of this talk with the next half of this activity with the next half next week. So we'll jump right in. Let's first talk about the effects of obesity on all of the organ systems. So I think a lot of us were trained where we really treated each of these problems individually, and we really didn't tie it all together with obesity as something that is driving a lot of these conditions. But now we know that obesity is really affecting every organ system, and many of our patients have multiple comorbidities related to obesity. So we can see migraine, pseudotumor cerebri, and IIH, dyslipidemia, hypercholesterolemia, MASLD, or what we used to call fatty liver, nephropathy, metabolic syndrome, type 2 diabetes, degenerative joint disease, venous stasis disease, gout, depression, sleep apnea, asthma, cardiovascular disease, hypertension, GERD, urinary incontinence, and PCOS, and that's not even all of them. But we do have a lot of conditions that are co-occurring with obesity. And the prevalence can be pretty high with a lot of these conditions. So about 75% of patients with hypertension have overweight or obesity. 38 to 88% of patients with PCOS, 50 to 75% of patients with MASLD, 80% at least of patients with type 2 diabetes, 45% of patients with sleep apnea, 72% of patients with GERD, 60% of those with osteoarthritis, and 60 to 70% with dyslipidemia. So among these conditions, overweight and obesity rates are really high. And I want to focus in particularly on diabetes. First, let's look at the incidence of the prevalence of diabetes, which is steadily increasing. As you might imagine, we've had an increase in obesity in the US, and we also have an increase in diabetes. But what I think is really striking is if you look at these orange bars, and these are the percent of people with diabetes who have obesity. So it is close to 80% at the last time it was measured. So that's people not just with overweight, but with a BMI over 30 in the US. So now you can answer our post-test. You can answer this question one more time. So go ahead and answer. So great. So diabetes has the most co-occurrence for sure. But honestly, all of these are really important comorbidities for our patient, and hypertension is really, really common as well. So how much weight loss do you need? So when we think about reducing complications, I often sit down with my patients in my obesity clinic and talk about what their goals are. And much of the time, their goals are to make their diabetes better, make their hypertension better, get their cholesterol better. I see a lot of women with PCOS. They want to have more regular periods. They want to be able to get pregnant. So what percentage of weight loss do we really need to be telling patients they need to hit to get an improvement? And of course, everyone's different. These are population-based estimates. But if we think about preventing diabetes, we think about a range of 3 to 10%. And the diabetes prevention program, where we first saw lifestyle to reverse the incidence of type 2 diabetes, sought to get patients to lose 7%. So the maximum benefit is probably around 10% for this. For hypertension, it's 5 to 15%, although at the upper levels, people's blood pressure is still going down even when they've hit the 15% range. For dyslipidemia, it's 3 to 15%, with triglycerides continuing to move even after 15%. For hyperglycemia, So even a small amount of weight loss can actually really help diabetes and hyperglycemia. So that's really important for your patients. And this, I think, is something that's really satisfying when you're treating obesity, because diabetes, hemoglobin A1C, and blood sugar gets better pretty fast, and so do triglycerides. And this continues to improve even at greater than 15%. If we think about MASLD, you probably need a decent amount of weight loss, probably at least 10%, to improve steatosis, inflammation, and mild fibrosis. Sleep apnea, I've seen studies ranging from 10 to 12% to really be able to improve sleep apnea. So that's important for our patients to know. For osteoarthritis, a lot of people feel a great improvement even with 5% weight loss, 10% weight loss, and even more. Stress incontinence usually needs 5 to 10% to get better. GERD is about 10% in males, 5 to 10% in females. And PCOS, we don't have as much data, but it's probably 5 to 15%, with at least 10% being optimal in terms of improving PCOS. So now we'll move on to the post-test question. So go ahead and answer this one. Great. So based on the data, 5 to 15%, we should see an improvement in hypertension. And it's important, I think, from the primary care perspective. I do both primary care and obesity medicine, and sometimes treat patients a little differently depending on the setting. It is important to think about when patients are losing weight who have hypertension, it is good to take a look at their meds and do some deprescribing as they are losing weight, so that we're not in a situation where patients become hypotensive or get dizzy and even fall in the setting of weight loss. Okay, so how do we decide whether or not someone has overweight or obesity? Well, the classic way we've done this, which is mostly because it's the easiest, is BMI. So it's practical, it's useful, and it's really good at the population level. And studies have shown that it aligns for most people pretty well with body fat percentage. But I always tell my patients it's not about individuals. This is really more of a population-based estimate. But we can tend to consider overweight as 25 to 30, obesity 30 to 40, and then obesity class 3 is 40 and higher. However, more recently, we've seen that we should use some different cutoffs for some populations. So if we have patients who are Asian, of Asian background, we use a lower cutoff. And the reason we do that is because they have metabolic complications at different levels of BMI. So we actually consider overweight in an Asian population to start at a BMI of 23. And then pre-obese to obese is in the 25 to 30 range. And what this means is that when we think about whether or not someone is eligible for medications, we might use 27.5, which is really the cutoff that a lot of people use for obesity in an Asian population. However, there are things that a BMI doesn't take into consideration, and it's important to talk about this with your patients. And I feel like classically, when you talk about BMI, people might talk about Arnold Schwarzenegger and talk about how his BMI would be like 38, but he was not obese when he was a bodybuilder. He just had a ton of muscle mass. And that's really true. We don't really take into account how much muscle mass someone has when we look at the BMI. We don't measure that. We don't measure their body fat. It doesn't take into account how heavy their bones are. And it doesn't take into account fitness. And we do know that fitness matters a lot for patients. There's some studies showing that fitness can actually predict mortality, even apart from body weight. So that's an important part also. Also, how a patient eats. So people can have a really different approach to their diet and their physical activity. Someone with a healthy lifestyle probably has decreased mortality, even at the same BMI. And then genetics and race matter also. So what else can we do? Well, we can also think about measuring waist circumference. And I don't know about you, but I rarely do this in my practice. We're just not used to it. And it's sort of like an extra step that we don't often do. But my medical assistants do know how to do it. So sometimes we'll go ahead and measure it in patients, and it can be useful. It can be useful to help predict disease for our patients, but also a way to measure, other than weight, how things are changing in their body as they're losing weight. This figure shows that waist circumference can really predict all-cause mortality. And the reason that matters is if we think about waist circumference, it represents central adiposity. And we know that central adiposity has an increased risk with mortality and cardiovascular disease and cardiometabolic disease. So it can be helpful. It can be helpful in addition to BMI, and it can be helpful for patients to have some other measure than just their body weight. So these figures are showing no matter what, the hazard ratio for all-cause mortality goes up with increasing waist circumference. So you can think of it as a risk modifier. So here's an example. So we have a patient who has a weight of 234 and a height of 70. So this patient has a BMI of 34 with a waist circumference of 45. So that's 45 inches. That's greater than the cutoff in men for a large waist. So then if we look here in this table, we can see this is actually a patient who had a normal waist circumference or a lower waist circumference and a BMI of 34 would be at high risk. This patient has an additional risk modifier that would be very high risk based on the waist circumference in addition to the BMI. So how do you measure waist circumference?
For patients with a BMI greater than 25 but less than 35, measuring waist circumference can provide additional information about the patient's risk of complications from obesity. The first step is to ensure that the patient is in a private location, such as an exam room, and ask for permission to take a waist circumference.
Your waist circumference can be an important indicator of your health. Is it okay if I take a quick measurement of your waist circumference?
With the patient's permission, ask them to stand up in front of you and have them lift their shirt out of the way to visualize the top of the iliac crest. Have the patient locate the top of their iliac crest and verify the location by palpating. Place one end of a tape measure just above the top of the iliac crest. Have the patient hold this end of the tape measure in place. While you hold the slack of the tape measure, ask the patient to slowly make a 360-degree turn. Once they have turned 360 degrees, ask them to release the tape to you and relax their arms at their side. Ensure that the tape measure is parallel to the ground. The tape measure should be snug but should not compress the skin. Ask the patient to take a deep breath and exhale. Take the measurement at the end of the exhalation.
So I think that's a really useful video. One of the parts that I like, I don't know how many of you have measured waist circumference, but I have done it before when I was like basically hugging the patient and trying to wrap it around their waist. And when you have the patient just hold it and spin around themselves, it can be a lot less invasive to do the measurement. And as that recording mentioned, it's really most useful in those middle ranges. So patients with a BMI above 35 or 40, they have increased risk already. You're probably not going to learn that much from doing the waist circumference, but in that middle range, it can really help you risk stratify the patients. Okay. We're going to move on to a case study. So this is a 42-year-old woman. She's at your office for her annual checkup. She weighs 197 pounds. Her height is 62. Her waist circumference is 41.5 inches. So her BMI is 36. Her blood pressure is 130/80. Heart rate is 90 and a normal cardiac exam. She's not on any medications. So you send out some blood work and then you set up a telehealth visit to discuss any findings from her labs. So you do a telehealth visit. Here are her lab results. So her glucose is 110. Her hemoglobin A1C was 5.9. Her total cholesterol was 200, LDL 112, HDL 50, triglycerides 148, and a normal eGFR greater than 60. So for the past 2 years, her cholesterol levels have been elevated. And now she's showing you with her fasting glucose and her A1C that she's now in the pre-diabetes range. Here's your telehealth visit. Okay, so, she agrees to a visit. So this physician really has the luxury of doing a lot of visits to get to the next level.
I feel so overwhelmed. I don't want to end up like my mom. She has type 2 diabetes and she's had a lot of complications with it. I just don't want that to happen to me.
Okay, so the patient comes in and you do an in-person visit to talk about her lab test results and her obesity. And this is a good time to think about how we discuss obesity. And historically, we have not been great at this. And I can tell you, I'm sure you have also talked to patients who feel really stigmatized about their weight, who have had bad experiences with physicians talking about their weight. And you can tell even, one of our terms we've used for years, it's still an ICD-9 code, is to say morbidly obese, which is really stigmatizing for patients. So we like to think about other ways to talk about weight that might be less stigmatizing, not blaming, and more motivating and encouraging. So I think one thing you can do is ask the patient how they want you to talk about it. And sometimes that can be the most helpful thing to do. But keep in mind some of these terms. So less motivating would be saying things like fat or chubby or extremely obese, and more motivating to say unhealthy weight, overweight, or weight problem. If you are saying fat or morbidly obese, extremely obese, or even obese itself, it can feel more blaming and stigmatizing, and better to say, weight, high BMI, unhealthy weight, or maybe weight problem or weight issue. We also try to use person first language. So we used to always say obese patient. So this is an obese patient with a history of blah, blah, blah. And now we try to say patient with obesity. So it's not, obesity isn't defining the patient. Obesity is one of the conditions that the patient happens to have. And I think it's important to be aware of unconscious bias. And we all have this. Even our patients with obesity have unconscious bias. But things to think about, just to keep at front of mind when talking to patients with obesity, is to focus on health rather than weight, to provide continuous non-judgmental feedback on progress, to recognize that obesity has many factors and many are outside of the person's control. And I feel like patients often talk about how they feel like all of obesity and their weight is about willpower. And if they had just been stronger in terms of willpower, they might have been more successful. I hear that from patients all the time. And I think really moving away from blaming or willpower and thinking about all of the factors that go into having obesity. It's also important to discuss and identify achievable, sustainable goals. Consider that most patients have had some weight bias that they've had previously. Most patients with obesity, at least the ones who come to see me, I would say most patients have tried to lose weight a lot. Most of them know very much about nutrition, very much about exercise. It's not really a knowledge problem. It's really, we need to talk about all of the factors going into obesity, and then to just be really kind and considerate when thinking about the issues that might be coming up there. And the other thing is just to explore all causes of the patient's presenting problems. And I've had multiple patients tell me they find it really frustrating, and they go in to see a physician and they tell them everything's because of their weight. So they've got knee pain. Well, if you lost weight, this would be better. They have back pain. Well, it's about your weight. You have GERD, it's about your weight. And I think that can be really frustrating. And patients often want to talk about all of the factors that are going into a problem, not just their weight or their obesity. So when you think about how to have the conversation, the way that you frame it matters also. And this is something that's different for me when I'm doing primary care versus obesity medicine. Patients who come to see me in my obesity clinic are already there to talk about obesity, but patients who are in my primary care clinic, I always ask permission. So something like, would you mind if we spoke about your weight, or how are you feeling about your weight? Where do you think you're at right now? I think can be a lot better than saying something like, that all of these issues you have are about your weight, or would be better if you lost weight. And then using person first language. So, individuals who have a higher weight, individuals who are larger, individuals with a higher BMI. And then being evidence-based. So you can't say, or you shouldn't say, if you don't lose weight, you'll get diabetes. Of course, not everyone is going to get diabetes, but really obesity can affect our health in these following ways. And I'm hoping that people wouldn't really say you just need to eat less, or don't you want to be at a normal weight? But these are other things that would feel stigmatizing or blaming for the patient. And instead, thinking about, what's been going on in your life since we last met? How has this had an impact on what you eat? Just thinking about, let them tell the story, and then you can do more listening. And ideally, if they feel less blamed, it can be a lot more successful conversation.
I feel so overwhelmed. I don't want to end up like my mom. She has type 2 diabetes and she's had a lot of complications with it. I just don't want that to happen to me.
That does sound overwhelming. I hear you. You want to make changes for your health and your future, and I'm here to lend support. Do you mind if we talk about your weight and where you feel you are right now?
Am I gonna get diabetes if I don't lose some weight? I'm not happy with my weight, but I just honestly I don't even know where to start. Ever since I lost weight a few years ago, it's just been so hard to not only lose more weight, but just even maintain the weight loss.
So I think that physician did a good job of being kind and listening and not being judgmental when she talked to the patient about her weight and her obesity. One thing I sometimes do as an exercise with patients is have them draw out what has happened in their weight trajectory. And this can be a really useful exercise. We used to have intake forms at my obesity clinic where they would actually fill this in over time, but sometimes we can just do it electronically too, say in a telehealth visit, to kind of hear how things have changed with weight over time. And another part is to look at what factors might have happened. So this patient started out, maybe above 265 and then did a subscription diet and exercise program, got weight down really low, lost about 70 pounds, and then had lots of ups and downs with a job layoff, a new job, a breakup, and some other factors. I also often put pregnancies in here and what happened for postpartum with weight loss and that sort of thing too. So this can be really helpful. The other thing that this shows us is that there is some metabolic adaptation, and that's what we're going to talk about next, that as patients lose weight and try to maintain at a lower weight, it can be more challenging and harder to stay at that weight than it would be to have stayed at the higher weight in terms of diet and exercise.
The slow upward drift in calorie intake on a new diet is not because you got lazy. Once your appetite is boosted by 600 calories after dieting for a while, eating 200 calories less at the end is as hard as eating 800 calories less at the beginning. So you can maintain the same disciplined level of willpower and self-control and still end up stagnating.
So I think we'll talk more about that, but that can be a helpful perspective to think about. So as a patient is at a certain weight, they need certain number of calories to maintain the weight. When they get down to a lower weight, two things are happening. First, their body weight needs less energy to sustain itself. And there's an adaptation their body is trying to, in many ways, kind of fight back to get to the higher weight. So both of those factors come into play to make it more challenging. And a patient might feel like they are doing amazing in their willpower, but they blame themselves for regaining weight. So I think it's just really important to understand what goes into that. And we can talk about the different components of total energy expenditure. RMR is the resting metabolic rate. So that's the baseline to keep your body going, to keep all of the functioning. Thermic effective food depends on what you eat. It's meal composition, protein and fiber, the content of food. It's also related to hydration. NEAT is non-exercise thermogenesis. You've probably heard maybe people who fidget a lot might burn more calories at rest. So it kind of depends on how much you fidget, how many hours you're awake versus asleep, what your daily steps are. All of that goes in, all of your non-exercise activity. And then exercise itself, this bar takes up a different amount depending on the person, but this will round out the total energy expenditure. So all of these factors are going into how much a patient is burning in terms of calories, what their total energy expenditure is, and it's influenced by weight loss.
During one season, some of the Biggest Loser contestants famously had their metabolic rates tracked. Above and beyond the hundreds of calories less it takes to just exist 100+ pounds lighter, by the end of the season their metabolic rate slowed by an extra 500 calories a day. The mind blower was that 6 years later they were retested and still had the 500 calorie a day handicap. So the contestants had to cut 500 calories more than anyone else their size to maintain the same weight loss. No wonder the bulk of their weight was regained. Most remained at least 10% lower than their starting weight, though, and even a 7% drop has been shown to cut diabetes rates about in half. Still, the metabolic slowing means you have to work that much harder than everyone else just to stay in place.
So I remember when that paper came out a few years ago, and it did get a lot of press. There have been some critiques of the paper. It's certainly an extreme example. The Biggest Loser isn't on TV anymore, but if you remember what happened during that show is that patients did or participants did an extreme amount of physical activity. So, most of the time it's difficult for patients to lose weight with physical activity because they have jobs. They can only work out maybe 30 to 60 minutes per day. And The Biggest Loser, they were working out for many, many hours. That is partly why it probably had such a big impact on metabolic adaptation. Other studies haven't shown as dramatic of a change, but it is certainly true that when you become weight reduced, you are going to need fewer calories to sustain, and that will probably be in addition to a metabolic adaptation to weight loss. So not only is your body, a 220-pound body going to a 185-pound body, just need fewer calories for resting metabolic rate, fewer calories for the amount of exercise you do, you would just burn fewer calories, but there's also some adaptation that's happening. So the patient has to eat even less. So less because of their smaller body size, and even less because of what has happened in terms of metabolic adaptation. And this figure is just showing what happens in terms of total energy expenditure over time, and that this is going down as the patient is losing weight. And it's affecting all of the pieces of the pie, so the RMR, the TEF, and the active energy expenditure. Okay, so let's get back to our case. So
Yeah, sure. So I work on film sets. I put up together all the different props and everything like that. It can be pretty physically demanding. I do work up a sweat as I'm setting it up, but once I'm done with that and the set is set up, I will sit down for most of the day. So as far as food goes, the studio usually provides us with meals, but they aren't really super healthy. Oh, and I also like to take walks with my boyfriend on the weekends. They typically will be about 45 minutes, maybe an hour long, depends on the weather. But honestly, just thinking about finding time to exercise more just seems really overwhelming.
I feel like that's a pretty classic patient communication. So the things to think about when you're at this point is thinking about shared decision making for your patient. So asking leading questions, clarifying information by repeating back what the patient said, trying not to interrupt the patient, and doing an assessment of motivation and confidence. And I often do this with a scale. I'll ask a patient, how important is it to lose weight on a scale from 1 to 10? And I also ask how confident they are to lose weight that they can lose weight on a scale from 1 to 10. And then I kind of use those numbers. So if they say that their importance is a 10, but their confidence is a 2, I might say, what do you think it would take to get up to an 8, or why are you a 2 and not an 8? And we kind of have a discussion about motivation and confidence. It's also important to communicate that you're there to help the patient and help her reach her goals, whatever those might be, acknowledging emotions and feelings. And weight can be a very fraught issue, as I'm sure all of you know. I have a lot of patients who will cry in my office or just reveal years and years of stigma and bias and feeling really out of body in their own body. So I think it's really important to just sit with those emotions and give your patient a chance to talk about her experience having obesity. Also using layman's terms to explain the physiology and the science, and then collaborate to identify what the next step might be. Use weight neutral terms, as we talked about, and instill confidence. The other piece is the education and counseling. So asking questions to make sure the patient understood, discussing specific diet, exercise, and monitoring goals, eliciting and addressing barriers to change, and explaining the nature of obesity, including the adaptation that can happen so patients know what to expect. And a lot of people will use a SMART goal format. So the idea is not something really general, like I'm going to eat less fast food or I'm going to start working out, but to be really specific. And I always write these down in my notes so that the next time the patient comes in, we can check in on how they did on the goals. So the goals should be specific. So who and what. Measurable. So how much are you going to do? Achievable. So not to go from I'm not really exercising much at all to I'm going to run a marathon, but really what are the goals that would be realistic? Also relevant. So why are they important to do, and time bound? So when are you actually going to do it? By what time, which days, and all of those specifics. I don't really tend to discourage my patients from having ambitious weight goals. There was a study showing that patients who had ambitious weight goals didn't do worse than those with more realistic, and they may even do better. So what I usually do is start with what goal they really have, and that might be to lose 50 or 60 pounds. But I usually start with a 10% weight loss goal, or a goal that aligns with the medical problem they're trying to address. So if it's diabetes or hypertension, to use one of those percentages to think about that as an initial goal. And then I say, we'll hit that goal, and then we'll get onto another goal once we've hit it. So some examples for our patient, our case study. The patient says she wants to have a frozen meal that has appropriate protein, grains, and vegetables for easy lunches rather than fast food. And portion control can be really well served by doing a frozen meal, because it's often hard to count calories in something that you make. And even when you buy it, it's somewhat inconsistent, maybe at different restaurants. But if you have a frozen meal, it's a great way to do portion control. She said she's going to walk 5 to 10 minutes per day during her lunch break, and she's going to add 2 fruits and 3 vegetables each day for a total of 5 days per week. So these would be some goals that are SMART goals, and then you could check back in with the patient to see how it's going. So this patient goes out with those goals and then comes back at 3 months and has lost 5 pounds and is disappointed with her progress. And I'd say this is pretty typical. We often might talk about working hard, say, I see you've been working hard according to the recommendations. We discuss that weight is a culmination of genetics, environment, and physiology. You can't change your genetics, but adjusting physiology using safe, effective medications can help weight loss and lower cardiovascular risk. And maybe this patient would be interested in medication. I will say in my practice, I don't necessarily insist that any patient do a 3-month trial of lifestyle if they want to work with medications. Our more recent studies have shown you're not going to do better necessarily if you do lifestyle first. So it really is, I do that very much depending on the patient. Some patients we might do lifestyle and medication right away. But let's just talk about the options we have in terms of meds. And so phentermine is our longest weight loss med. We started using it in the 1950s. It was part of fen-phen, but it's considered to be the less harmful part of fen-phen. The other one was fenfluramine, which they think was causing almost all, if not all, of the valvular disease. So phentermine we can use. It's it's an appetite suppressant, so it can help decrease appetite. There's a 15 milligram and 30 milligram dosing, and also the 8 milligram form that you can use up to TID. Although I tend to just use it twice a day, since patients who take it close to bedtime sometimes have trouble with insomnia. It says a short-term 12 weeks. I can say in the field of obesity medicine, we often use it for longer. There are some more recent studies showing that longer-term use is safe. So patients who don't have other risk factors for being on a long-term medication in this class, I often will use it longer. And I think it's really frustrating for patients. Sometimes their PCP will only use it for 12 weeks and they lose a good amount of weight, and then they gain it right back as soon as they stop the medication. Orlistat is a medication I don't use very much, but it's an option. It's a gastrointestinal lipase inhibitor. It decreases fat absorption. You can take it up to 3 times a day, and there's about 3 to 4% weight loss from it. Phentermine topiramate combination I use quite a bit. This is an oral medication. It decreases appetite. It's a once-a-day med if you use the brand name. Obviously, you can also break it up and prescribe these 2 meds separately. And I've seen for some patients have really great weight loss from this. Officially, it's about 5 to 10%. Another one is naltrexone bupropion. This medication is also decreased appetite. It's the combination of an opioid receptor antagonist. Naltrexone, we use it also to decrease the alcohol or opioid use. And then bupropion, which is in one of our antidepressants. This is taken twice a day and has about 4 to 6% weight loss. And the last one in this first generation is liraglutide. And this is a GLP-1 receptor agonist, but it's one of the earlier ones that's taken every day sub-Q. And the weight loss is about 5 to 7%. Just a few things to go over about these medications. So phentermine, common side effects I see are dry mouth, insomnia, headache, fatigue, and palpitations. More serious, a low but serious risk of pulmonary hypertension and cardiac valvular disease. You do want to be careful in patients with hypertension. I just monitor it. Usually patients with well-controlled hypertension are fine. Patients who might be at risk for abuse dependence, although studies have shown that this risk is pretty low with phentermine. The drug-drug interactions include alcohol, although if you look this up, you can't really find why, and then MAOIs as well. Orlistat, we see some upper respiratory infection, headache, oily spotting, abdominal pain, flatulence with discharge, fecal urgency, fatty oils, oily stool. Once I start telling patients about like fecal urgency and fatty stool, most patients decide not to do this. But one of the things that can be really nice about orlistat is many patients who can't take any other medications can take this one. So some drug-drug interactions are listed here too, including fat-soluble vitamins, levothyroxine, just you have to take it 4 hours apart in time, and warfarin. And then phentermine topiramate, I do use this one a lot. We do sometimes see constipation. Paresthesias are pretty common. I always warn patients, you might have tingling in your fingers and toes, sometimes even in your face. I do this in part because I have had patients, even though I felt like I told them that, go to the ER because they thought they were having a stroke. But so that's really common. It gets better over time for almost everybody. Dry mouth, upper respiratory infections as well. Patients who have a mental health history, I do warn them about if they have any suicidal behavior or ideation, just to know that it's the medication. Let me know right away and we can stop the medication. Also acute angle glaucoma, mood, sleep disorders, cognitive impairment, metabolic acidosis, decreased renal function, and serious skin reactions. If we think about the next one is naltrexone bupropion, so commonly some nausea, maybe some psychiatric or sleep disorders, constipation, headache, vomiting. I really haven't seen that, but I know it's listed in the adverse events. More serious would be seizure, hepatotoxicity, or angle closure glaucoma. Not to be used if this actually can increase blood pressure even more than phentermine, surprisingly. So you have to be careful with uncontrolled hypertension, also seizure disorders, eating disorders, or chronic opioids. Obviously, if you're taking naltrexone and taking opioids, it's going to block the effect of your opioids. Liraglutide, commonly, just like all GLP-1s, we see a lot of nausea, diarrhea, constipation, injection site reaction, and headache. You could also see hypoglycemia or dyspepsia. The most serious issues would be acute pancreatitis, gallbladder disease, increased heart rate, or renal impairment. There is some controversy about whether or not GLP-1s do have a risk of suicidal behavior. I've seen some studies recently showing that they haven't really seen a link, but something to think about with all GLP-1s, you can't have a personal or family history of medullary thyroid cancer or MEN2. Okay, the second generation's AOMs, you're going to go into these a lot more next week. So I'll just say briefly, they are defined as second generation because they can produce an average of more than 10% placebo-subtracted weight loss in the majority of trials in the majority of patients. And they can safely produce more than 15% weight loss in over half the patients as an adjunct to lifestyle. So the two meds that we think about in this class, there are a lot of meds coming, but the ones that are currently available include semaglutide and tirzepatide. Semaglutide is a GLP-1. It decreases appetite. You take it sub-Q once a week. And then tirzepatide is a dual agonist. So it's a GLP-1 receptor agonist. It has a little bit more weight loss in the published studies, 15 to 21% weight loss. So now on to one of our questions. Let's go ahead and answer this one. Good. So it's 15% weight loss in over half the patients is the right answer. So great job. It is a once a week injection, not daily. Okay. So we have a great video to explain how the GIP and GLP-1 agonists work.
GLP-1 and GIP. The GLP-1 is a hormone produced in the small and large intestines. It is released in response to food intake and stimulates insulin secretion and suppresses the glucagon secretions, but only when there is glucose in the bloodstream. The GLP-1 has also other beneficial effects. It slows the absorption of carbohydrates, resulting in low blood glucose levels after meals. It also causes loss of appetite, and animal studies have shown that it can promote the regeneration of pancreatic beta cells and improve the survival of existing beta cells. The GIP hormones are produced by cells in the upper small intestine, and they are released when glucose comes into contact with these cells. Like GLP-1, the GIP acts on pancreatic beta cells, where it stimulates insulin secretion and also appears to promote beta cell proliferation and survival. GIP may complement the action of GLP-1 receptor agonists. In preclinical models, GIP has been shown to decrease food intake and increase energy expenditure. Therefore, the combination with a GLP-1 receptor agonist may have greater effects on markers of metabolic dysfunction, such as body weight, glucose, and lipids.
Great, and that is the end of the presentation for tonight. Hopefully people have some questions. Thank you so much to all of you for listening.
We do have some questions. What strategies can help address patient hesitancy or skepticism about weight loss medications, particularly among those who may have tried multiple unsuccessful treatments in the past?
That's a great question. I think it can have a different approach depending on the patient and what they've tried before. I mean, we all have patients who just absolutely say they would never do a medication, and I see that a lot with surgery, bariatric surgery as well. But if a patient hasn't tried one of the newer medications, I do talk about the benefits of our newer AOM medications because they may have had no success with previous medications, and I've seen lots of patients actually lose weight successfully when they use one of the newer medications like tirzepatide or semaglutide. So that can be something to consider. And I also talk about, physiology, that these meds are actually addressing what's going on at the physiological level, not just trying to reduce your appetite, not just an appetite suppressant, but actually acting on the gut, on the brain, even affecting the insulin release and some other factors related to the physiology. So sometimes patients will be willing to try it based on that. But I never force anyone. We can always just work on diet and exercise too.
How can I acknowledge and respect cultural, personal, and family influences on weight and health that may impact the patient's perception and acceptance of treatment?
I think that's a really great question. When I get to do an obesity in my obesity clinic, my intake, my first visit is an hour. So I do have the luxury of really getting into the whole history of a patient's weight. And I have a whole part where I ask about family. I ask about colleagues. I ask about the work environment. A lot of people have difficult work environments where people are bringing in a lot of, like cookies and cakes and candy and that sort of thing, especially this time of year. So I think that part is really important too. Also, just thinking about cultural practices. So, if a patient needs to be fasting for Ramadan, then you need to think about like, how are you going to adjust their weight loss regimen accordingly? Where are you going to put their calories? So I think just like taking time to listen. I also do both a full diet recall, so at least a 24-hour recall, and then I ask them about eating out and preparing food at home and meal planning and that sort of thing too. So it gives you a good sense of the type of foods that they're eating, and I think that can be really helpful when you think about counseling them in terms of diet and physical activity.
All right, a couple more. How do I respond to patients' concerns about relying on medication for weight management, especially when long-term treatment may be recommended?
Yeah, such a good question. I feel like I get that question all the time. And I think I usually will think about medication when we talk about it, that if possible, they probably want to try to continue the medication long term. So we have really mixed data on this, and it's hard to figure out what to do with patients who have to come off medication, which I see all the time because of availability or insurance coverage, or just they can no longer pay out of pocket. And I have strategies to think about patients like that. But often if patients find the medication helpful and they can continue on it, we think about it, more like hypertension. So if we got your blood pressure down with a medication for hypertension, if we stopped it, your blood pressure is going to go back up. And that's typically what happens in the studies when people go on a weight loss medication and then come off. So that if you can think about it as more treating your chronic condition, which is your obesity, that maybe you would be willing to think of it just along with all of your other medications. It's also helpful that particularly some of our newer medications, our GLP-1s, also have efficacy for improving cardiovascular disease outcomes, for improving MASLD or fatty liver disease, and for improving sleep apnea. So those are all papers that have come out in the past year on these medications showing improvement. So patients who have those conditions, it can also be really helpful to say, we're not just treating your weight. This is also a way to decrease your risk of having a heart attack or stroke in the future, for example.
What can I do to help ensure my lower income patients receive the same quality of obesity treatment as those with better insurance or higher incomes?
Such a good question, and I don't think I have a good answer for that. I wish I did. Here in Colorado, Medicaid does not cover our weight loss medications in general. Medicare will cover, we can get them to cover semaglutide for patients who have a cardiovascular event history. So at least in my experience, I can get it covered if a patient has a history of an MI or a stroke. But if they just have known cardiovascular disease or a risk for cardiovascular disease, I haven't been able to get that covered. So the equity is a huge problem, and it's probably a problem where everyone is playing a role. The insurers, the drug companies, everybody is playing a role in making these medications harder to get, and the availability, which has seemed to be getting better over the past 3 months. So I think we have to lobby to get everyone access to these medications, and all the players would probably need to do their part to help make these more affordable and accessible for patients. So I think that's a huge problem. And once we're in a situation where we have more generic options, that will probably be better. For now, we need to figure this out. These medications are really powerful and they help patients a lot. So figuring out how to make it equitable, I think, is a huge issue.
What is your opinion on compounded oral semaglutide formulations?
Great question. I'm sure all of you have patients asking about this all the time, and it's partly that accessibility issue. So for many of my patients, insurance isn't covering these medications. Paying for the commercial product out of pocket can be really cost prohibitive for a lot of patients. So patients are looking for other options. If you look at some of the guidance from the FDA, they've come out against compounded semaglutide and compounded tirzepatide because there have been some studies showing impurities, or that people aren't getting what they thought they were getting, and even people going in for acute medical care because they took the wrong dose. On the other hand, I think there are good players in this space who know how to do compounded medication and are probably doing a good job for it. So I do have patients using it. It's not something that I prescribe, but I know for some patients it's the only option. And I think then it's partly just doing due diligence to make sure that they're using a reputable compounded source. But I think this is a really tricky question. It's also, they've been able to compound medications that are in shortage. And my understanding is that tirzepatide just came out of shortage. So, but semaglutide is still technically in a shortage situation. So I think that's going to affect the availability of compounded medications as well.
How can I manage disruptions in care for patients who begin GLP-1, GIP therapies, and then lose access due to changes in insurance or personal finances?
Such a great question. This is, I feel like, my everyday. So we need studies on this. We need to do research to figure out how to do this best. I can say right now I deal with this on a case-by-case basis. I have a couple of very rare patients who've been able to maintain their weight off of medication. There was a European study that came out a few months ago showing with a lot of exercise, I think patients were able to maintain their weight decently. But I would say if you look at the published research, and most of my patients, if they come off of a medication, especially semaglutide or tirzepatide, abruptly, they do tend to regain weight. So in that situation, I will typically see if I can get a different if their insurance will cover a different medication, say an oral medication, maybe naltrexone, bupropion, or phentermine, topiramate. Those might be good options. I've had decent success with patients switching to a different weight loss medication. Or some patients will do kind of spacing. We don't have data on this at all, but maybe they'll go every 10 days to see if they can get, or every 14 days to have their medication last longer in a way that they can actually afford to continue. So I think it's a major issue. Hopefully we will have more research coming out about what to do in this situation. But those are some of the strategies I've used just on a case-by-case basis with my patients.
Okay. Well, thank you so much, Dr. Nicholas, for a wonderful discussion. For those of you on the line, if you're interested in claiming continuing education credit for this, please visit mli.link/obesityco1 or scan the QR code on the screen. And we look forward to seeing you all at the same time, same place next Wednesday. Great night.